Thank you, Rob. Those are amazing cases. So this is our fifth and final session on practical aspects of lead extraction. We have three talks: Dr. Thomas Callahan, Dr. Isaac Whitman, and Dr. Russell Denman. And then we will follow with a question and answer period after.
Hi, I'm Tom Callahan, one of the lead extractors at Cleveland Clinic. I'll be talking about lead extraction in unique scenarios. I'd like to thank Rob and the organizers for the opportunity to be part of this great meeting. My disclosures, and we'll jump right in. So I'm hoping that we can make it through three cases today. We'll talk about a lead fragment, an other fragment, and then a sort of a unique scenario for removal of a leadless device. And all of these will involve some kind of snaring, so that'll be the theme that ties it all together. So we'll jump right in. We'll start with case B. This is a 42-year-old female with a history of congenital aortic stenosis. She's had a valvuloplasty at a very young age, 1983, then a Ross procedure, transcatheter PVR, and then multiple pacemaker procedures. I think she had her first pacemaker implanted when she was about 4 years old, and I think it was implanted from the right side with the device in the abdominal location. Eventually, that was partially removed, and she underwent a left-sided pacemaker. She had thoracic outlet syndrome, so that was removed, and she ended up with, most recently, a ventricular AV synchronous leadless pacemaker. So she presented to our institution with prosthetic pulmonic valve endocarditis and underwent her fifth open heart surgery to remove the infected valve, as well as deal with a infected RA to PV conduit. And they attempted to remove this remnant pacemaker lead from 1985, and the surgeons said that when they pulled on the lead, they thought they got the whole thing out, but the next day on chest X-ray realized that there was a significant portion of this lead remaining, and since she was infected, the hope was to have this remnant extracted. So she came our way, and looking at the chest X-ray as well as talking to the surgeons, it looked like the reason they thought they had removed the whole thing is the length seemed appropriate, but it looked like the inner coil, the entirety of the inner coil had come out when they pulled on the lead from below, but the outer coil and insulation for a significant portion of the lead were left in place. Here's the chest X-ray, and you can see that lead remnant on the right side. You can see she has a loop recorder and then that micra as well. So the lead extended basically from the right-sided pocket. There was just a little bit that was accessible outside of the vascular space, and it's a little hard to tell from this chest X-ray, but it sort of terminates in the mid SVC region. This I thought would be a challenge, really, to remove. It's an old lead from about 1985. We have just the outer coil as well as the outer insulation. The inner coil and inner insulation are gone. So locking stylet's not going to fill the lumen very well. I expect it was going to be densely adhered inside the vasculature, so I can't just pull on it. And I thought if I did pull on the part that I could access from the pocket, I'd probably get a great radiographic result, but not an optimal clinical result for it, because almost certainly I'd leave behind a fair bit of the outer insulation. So I needed to find a way to both create a rail and then get over this with some extraction tools to hopefully get the insulation out. My initial idea was to place a locking stylet down the lumen of the outer coil, and I thought if I get a locking stylet down, then maybe I could snare it from below. I wasn't overly optimistic that even with a larger locking stylet that I'd be able to sort of truly lock the outer coil, but hopeful that it would at least serve as a rail for me. The problem that I ran into, though, was that despite trying multiple locking stylets, they all sort of passed between the coils. So instead of making that acute bend from the right subclavian down into the SVC, the locking stylets each time would just sort of pass in between the coils, and you could kind of feel it just bang against the wall there, and it would never go the full length of the lead. So after some thought, I decided what I'd try instead is actually a bigger wire. So I went with a woolly wire with the flexible tip, but also just sort of just a larger diameter wire, hoping that it would sort of bump across those coils instead of going in between them. And in fact, that's what it did. So that one actually passed very easily down the lumen. And once I had the woolly wire down that outer coil, I was able to snare that from below with a femoral workstation. So now I had at least a rail to work with. I used a compression coil at the pocket site to kind of bind the lead components to that woolly wire, and then I started to work from above. So I initially started with I think it was a 16 French laser. My idea was I didn't want to damage the insulation as I was just kind of getting into the vessel, and I thought the laser gave me the best chance of kind of getting up and over, and I knew I'd be able to work with that outer sheath as well. So I made some really nice progress initially, kind of made that turn into the SVC, and then kind of got hung up in that high SVC, and you can see I'm trying to reset and applying some laser, and even there you can start to see I'm snow plowing some of the lead and insulation. So it was clear to me I was not going to make any further progress with that laser. So then began working with the outer sheath, trying to get over whatever it was that I was snow plowing in front of me, whether it was tissue or insulation. Really didn't make a lot of progress with that outer sheath, so moved on to a powered mechanical sheath, and started to try and work through some of that dense fibrosis that was impeding my progress. And again, was really just slow going, really tough sledding there. And finally tried with the outer sheath with the mechanical, and finally made some nice progress over that area that was giving me trouble. Finally made it down to the snare, and then the lead was free, and I was able to pull it out completely. Of course, in my excitement, I forgot to get an actual photo of the lead, but what I did do, and hopefully you'll take my word for it, I put the lead, and kind of measured it out on her chest, and I had not just the coil, which gave me the radiographic success, but insulation, basically the entire length, down to measured out to that sort of mid SVC. So we got a nice result for this lady, and she's been cleared. She's cleared her infection. So did a great, got a nice result for her. We took out the loop recorder, which was giving her some trouble as well. She found that painful. All right, so we'll move on to another sort of unique scenario. This is case CS. This is a 81-year-old female with stage 4 lung cancer, hypertension, hyperlipidemia, and she had a Mediport, right-sided Mediport. And while I don't have a whole lot of experience with Mediports, I guess these can break sometimes, and hers, in fact, had a fracture of the Mediport. So she went to interventional radiology, and they attempted to remove the fragment that had broken off, but were unsuccessful, and then called me because of the location. So here's the Mediport in place, and you can see that extending down the SVC into the RA. And then this is the subsequent chest X-ray, and you can clearly see here the fracture with the different ends of the Mediport, and you see that distal fragment just kind of sitting in the heart. And when we go to the lateral chest X-ray, you can appreciate that this has migrated out the coronary sinus. And here's a CT scan as well that shows the Mediport fragment that somehow is extended from the RA and migrated. The tip of this thing has migrated out the coronary sinus. So interventional radiology, this is a still from their attempt. They had attempted from the neck, trying a gooseneck snare to get on the end of this that was in the RA, but with no success, and then tried with a catheter to sort of sweep the mid-body, or to kind of grasp the mid-body, and again with no success. And I should say that the time between the fracture and when she was being treated by interventional radiology was a few weeks, I think close to 6 weeks. So there had been some time for a little bit of adhesion to form around this catheter. So when they were unsuccessful, they sort of closed up shop on that day, and then gave me a call. So a couple days later, we went and tried again, and this was in the interventional radiology suite. So initially, I tried from below, basically trying to replicate what they had done from above. I tried with a snare from above, and trying all my attempts to get over the sort of RA end of this were unsuccessful. I thought with an EP catheter, I might be able to sweep everything, or at least the proximal part down into the IVC, but that too was unsuccessful. I couldn't get around the mid body of that lead, even near the CS os. I was unsuccessful. So ultimately decided to see if we could get out the coronary sinus and kind of get at this fragment that way. So you can see here I've used an EP catheter through a steerable sheath, and I'm accessing the coronary sinus. And then was able to get the steerable sheath kind of pretty well into the body of the coronary sinus. And here we have a micro snare. I've written micro catheter, but it's a micro snare that's out past the tip. So we're in the CS body, but out past the tip of that lead fragment. Once we were past the tip, I opened up the snare and we just kind of brought it back towards our sheath. And even with our first pass, we got lucky, and the snare was over the catheter fragment, over the metaport fragment. So I gave it a little squeeze, made sure that I was in fact over the body of the catheter. And then rather than trying to pull it out there, I was worried it would start to double in the coronary sinus. It might give me some trouble. So I walked the snare back to the coronary sinus os. And then once we were sort of just outside the coronary sinus, oops, sorry, I wanted to let that run. Once we were outside the coronary sinus, I was able to tighten that snare and then pull out the catheter fragment entirely. So we used a micro snare out the coronary sinus over the distal end of that catheter, and we were able to get a nice result for that patient as well. So final case that I want to talk about, this is a wandering atrial pacemaker, but not the kind you're thinking about. This is a 79-year-old male with a history of hypertension, hyperlipidemia, lung cancer that had been treated, colon cancer that had been treated, and then paroxysmal atrial fibrillation, for which was causing him tachycardia, bradycardia syndrome. And after talking to one of my colleagues, he opted for a dual chamber leadless pacemaker, had a nice radiographic result on implant of the dual chamber leadless pacemaker. And the following morning, he was heading down for his device check, and he noted that his leg was rhythmically twitching. So we got a detour on the way down to the device clinic. Instead, he went to radiology and got a KUB, and you can see that leadless pacemaker, which is now in the femoral vein. So thinking about how to get to this, I mean, it was recently dislodged, so I didn't think there would be a problem in pulling it out, but it was just a matter of how to get to it. So I thought if I started from below on that right femoral vein, which is how we had implanted, I just wouldn't have a lot of running room, with that very large retrieval sheath. I'd only have a couple centimeters in, and I just didn't think it'd give me a lot of room to work. I could have gone from the contralateral side, but that would have involved a little bit more twists and turns, and I thought that would be a little bit more challenging as well. So ultimately what I decided is to go from the right IJ. I just used a 7 French sheath, and then through that 7 French sheath, used a gooseneck snare and went down to grab the device. So this is the initial position. And then this is with the gooseneck snare. Just through a 7 French sheath, we were able to grasp the main body of the leadless pacemaker and tighten down on the body. I never really secured the button because it actually pulled back nicely just around the main body. So here we're drawing it away from the femoral vein back up into the IVC. And once we had the device into the IVC, used the retrieval catheter, and I just grabbed the wrong end of it. I sort of grabbed it backwards, but because I had it snared from both ends, I was able to control it, keep it from sort of T-boning, if you will, and was able to sort of dock the wrong end, advance the protective sleeve. At which points I released the upper snare and was able to pull everything out from below. So, in conclusion, successful extraction, as we all know, often requires some creativity to solve some of the unique scenarios that we encounter. Snares, femoral or otherwise, can extend our options. And once again, thanks for the opportunity to participate.
My name is Ziggy Whitman, and I'm thrilled to be presenting this topic, lead management at the time of heart transplant. Cardiac EP is quite involved in the care of heart failure patients. As electrophysiologists, we do all these things listed here. But as the patient goes to the operating room for heart transplant, we're no longer involved. They get a young, healthy heart, the ICD is gone, and so are we. And my goal is to present an argument that we should actually remain involved in the patient's care, even going into and out of the heart transplant. So here's the current surgical approach for patients coming to the operating room. The current surgical approach is the patient comes into the OR, the chest is opened, and an incision is made where I have this violet oval below the pericardial reflection. And this reveals the ICD leads that are invariably in place. Traction is placed on these leads, which have been exposed surgically through the SVC. Traction's pulled on them. The leads are cut. The leads then retract, as you see in the next panel, into the superior part of the SVC or the innominate. And the distal portion of the transected leads are left in the native heart. The native heart's removed from the pericardial well. The donor heart is transplanted into the patient. And at the end of the case, the pocket's opened and the surgeon puts traction on the leads that remain in the innominate vein and tries to pull them out. And when that's done, sometimes you end up with this top chest x-ray after the case, which is a transplanted heart with the absence of any retained lead fragments. And sometimes you end up with the bottom one, which is a transplanted heart with a very obvious presence of a retained lead fragment. And those fragments are the topic of this talk. So we know some things about unnecessary leads in the vasculature. So for example, lead abandonment at the time of revision. We try to avoid it. It's associated with an increased risk of infection later. And we all know certainly complicates future extraction when extraction is necessary. When we extract leads for infection, any retained fragments are associated with then recurrent infection thereafter. Fragments at the time of or retained after heart transplant are a known phenomenon, and the implications of their presence is an ongoing topic of research. But nonetheless, we still know a few things about them. First of all, fragments after heart transplant, retained fragments after heart transplant, have been associated with increased fluoro time at the time of right heart or at the time of graft biopsy. Now, I'm going to discount this actually because that really shouldn't be the case. That's probably hypervigilance about coming into contact with these fragments at the time of dropping the bioptone for biopsy. So let's just put that aside. The presence of these fragments have been associated with an increased risk of upper extremity DVT after transplant. They've also been associated with reduced MRI use after transplant in a population, by the way, that gets a lot of MRIs. But again, I'm going to put this aside. This is a trigger issue for all electrophysiologists because it shouldn't reduce the use of MRI. And in fact, MRIs have been shown to be safe in heart transplant patients with retained lead fragments, which is no surprise to anyone here. But nonetheless, these fragments have been reported to migrate into the mediastinum, for example, and they've been reported to embolize both intraoperatively and postoperatively, and the object embolized has been reported as the entire fragment in some cases, or endoluminal components. That endoluminal components of these leads can embolize is something that I hope we touch on during the panel portion of this presentation, and I'm sure we will. But what about infection? That's the elephant in the room. How about the risk of infection for these patients who have retained lead fragments after heart transplant? Well, based on our own investigation at Temple, and this is currently unpublished work, but it's being presented at Heart Rhythm, so I won't give all the punchlines, and I hope will be published in a journal soon. Bacteremia is actually really common in heart transplant patients. That's demonstrated by us. We measured approximately 25% incidence of bacteremia after heart transplant. That's consistent with what others have found too. And bacteremia was more common in those patients with fragments than without, although this didn't reach statistical significance. Of those with fragments, 25% had gram-positive fragments or yeast, and 8% of them had Staph aureus or yeast. And in our study, recurrent bacteremia was more common in those with fragments, and that did reach statistical significance. In others' work, bacteremia has actually been shown to occur more than 30% of the time late. Said another way, not all bacteremia that occurs in these patients is going to occur in the immediate postoperative period. When you have retained fragments, or even if you don't, your infection risk as an immunocompromised person persists. It doesn't go away. And so the risk of infection is probably underappreciated in heart transplant patients, and specifically those with fragments, retained fragments, because studies on this topic to date have been small and short. In fact, it reminds me a little bit of the AFFIRM trial from the New England Journal in 2022, looking at rate versus rhythm control, and it showed that there was no difference. The average age in that study was 65 years old, and median follow-up was 3.5 years, too short to measure the implications of just rate control in those patients. So that at any given center, the comparison often between those with fragments and those without, and the infection implications in comparing the two, fails to reach statistical significance, is important to note, and that's a fact. But p-values don't replace feasibility and plausibility, nor do they replace what we know about retained leads and fragments in other contexts. What I can tell you is that these fragments aren't good, and they might be quite bad. We've all, or many of us, have seen it at least anecdotally. So this is what some of these fragments look like. Here's a very obvious fragment, and some of them are very obvious to see. Here's a retained coil in the innominate and subclavian. This one's harder to see. You can see it coming in, extending from the subclavian all the way to the distal innominate. Here's a little coil, and if you look really carefully, you can see a conductor that runs all the way up here into the subclavian. And this one's also harder to see, but you can see this present in the subclavian here. Here's an obvious one with 3 lead fragments retained. Another one here, just giving you more examples, an obvious one, and another quite obvious one of a SVC coil. From our study, this was the distribution of fragments. The innominate vein was the most common vein segment for a fragment. And frightening, every 5 years of increased dwell time of a lead going into transplant was associated with double the risk of a retained fragment. But frighteningly or shockingly or both, the youngest fragment in our study was only 1.4 years old. But the plot thickens. We argue, and we show in our study, that these fragments are probably more common than we think, despite prior estimates of 20 to 40% of transplant patients. There are hidden fragments. And when you compare two groups, for example, with fragments and those without, but those without fragments actually do have fragments, and I'll show you why in a second. What you do is you make those two groups more similar or more homogeneous. And so that any comparison between those two groups is more likely to be biased toward the null or biased toward showing no difference. Now, this is complete conjecture, but it's a statistically plausible conjecture. And why might this be true? Because not all fragments are visible by chest X-ray. And here's an example of that. Here's a chest X-ray that looks great after a heart transplant. No retained fragments, you think. But here's the CT scan in that same patient. And you can see here that there's some retained insulation in the patient's innominate vein. In fact, in our study, over 30% of patients that didn't have a fragment, at least by chest X-ray, also did not have the more sensitive exam for fragments, which is a CT, which is to say that in those 30% whom we categorize as having no fragments, they actually might have fragments, or some of them may. And these retained insulation fragments are extremely relevant. In fact, bacteria forms biofilms on insulation. That's why we do extraction for bacteremia to begin with. So these fragments that we don't see by chest X-ray, but are hiding more or less in plain sight, are just as relevant as the fragments that are seen by chest X-ray. And if it isn't clear looking at those fragments by imaging, these fragments of the chest X-rays I've showed you already, these fragments are often not extractable. The leads have been put under traction in the pocket and pulled and then cut, and they recoil into the subclavian or the innominate veins. So they can't be reached without surgery, often without reduced stenotomy. And that operation just isn't feasible. So what should we do, if anything? What we should do is weigh the risks of fragments versus the risk of extraction. And in the one published report of a protocol of post-transplant staged elective extraction, there were actually 0 complications. Now, do we alter the prognosis of transplant patients by removing these fragments? I think we probably do. And so what I would say is that we either need to extract these leads or just leave the leads alone without entering the pocket, leave the pocket closed to allow for later extraction if and when it's necessary to extract them for infectious reasons, for example. The current approach of attempting to remove at the time of surgery with just traction is almost by design just creates inextractable fragments. And that's the point. That's what we need to avoid. So based on our own data, at Tempo, we've started a protocol that's in its infancy. All patients who are listed for heart transplants CEP for the specific reason to comment on how to manage the device in the OR. And we provide one of two recommendations. Either one, try and open the pocket and try and pull out the leads. But if there's any resistance, stop. And you can remove the generator, but do not cut the leads. So one option is to try and pull out the leads, but stop if there's resistance. And the second option is don't even bother going in the pocket and just leave the leads. The point is never, ever cut the leads in the pocket because that may render these fragments inextractable later. There's some important points to consider when thinking about a staged approach to ICD leads at the time of transplant. One is that lead fragment behavior is different than lead behavior in our typical extractions. Their tensile strength is reduced, and their components, the conductors, the filars, the insulation, may be independent from one another as they're no longer fixed to one another at either end of the lead. Often, in order to extract these leads, they will, by definition, have been cut in the SVC or innominate, and also cut in the pocket by us for extraction reasons so that you can prepare the lead for extraction. And the behavior of a lead that is not bound at either end is different than the leads we typically extract that are bound distally. It's occurred to us also to explore the surgeons doing minimal dissection in the SVC at the time of transecting the lead to make any portion of the fragment that extends into the SVC more likely to be completely free at the time of a later extraction. And then because most of these leads are present in just these fragments are present just in the subclavian and innominate, and maybe the distal portion in the SVC is quite innocuous to address and extract, do we even need inferior access for these patients coming to the OR for lead fragment extraction? That's a provocative question and a question we haven't answered, but something we've tossed around in our group. And certainly, we need more information about in whom to leave the leads untouched, to say to surgeons, please don't touch this, versus in whom we should recommend that they just give it a try. I would have said in young leads, just go ahead and give it a try. But the lead fragment in our study that was only 1.5 years old that was retained is discouraging and makes us question just at what stage these leads should be left alone, at what dwell time. So finally, we suggest, again, one of these two approaches: either leave the generator and leads at the time of transplant as they are and extract them as needed down the road, or plan an elective staged extraction after transplants once the patient has recovered if the leads can't be easily removed in the OR, again, without cutting the leads. In the first possibility, just leaving the leads and removing them only later as needed, there's the morbidity of the patient out even after transplant having a generator, and dwell time would accumulate over time, but maybe neither of those is a huge deal, as most of these extractions will be relatively straightforward. So the risk of this first approach, we believe, is certainly low. And again, in the second approach, we also think the risk is low and maybe a benefit. So To those of us in the room, I would encourage you to join the transplant team. Share your knowledge about lead fragments. None of us knows what we do not know, and that includes the heart failure doctors and surgeons. And in both those groups, in discussing this topic with them, they have been extremely open to learning about a topic of which they actually hadn't thought much previously. So let's lean in on lead management at the time of heart transplant and be a part of the team so that we can affect the outcomes of these patients and minimize the likelihood of retained fragments after heart transplant. Thanks for having me. I look forward to the discussion.
Thanks very much for the kind invite to allow me to present this afternoon. My name's Russell Denman. I'm from the Prince Charles Hospital in Brisbane, Australia. I've been asked to talk in the next 15 minutes about the Australian lead extraction experience. I have no disclosures in relation to this talk. Just a little bit of background about Australia. We're a large continent in the Southern Hemisphere. It's in fact the 6th largest country in the world. It's got a relatively small population of 27 million. And unlike the Hollywood myths, most of us live in an urban environment, clustered around the eastern seaboard, around the large population centres of Brisbane, where I live, Sydney, Melbourne, and Adelaide. When I first commenced lead extraction in the early 2000s, it was a procedure that wasn't commonly performed. It was performed in a variety of locations, either the EP lab, the catheter laboratory, or the operating room. The hybrid operating rooms of today had yet to be invented. Surgical backup also varied. The procedure was performed in hospitals without cardiac surgical backup, and then even in hospitals with cardiac surgical backup, the surgeons may or may not have been informed of the procedure being performed and may or may not have even been in the hospital. At the same time, there was no physician reimbursement. The hospital reimbursement for the equipment did not exist. There were limited tools, and certainly when I started the procedure, we had access to the bird dilating sheaths and a locking stiletto, and there was no real governance of the procedure. In the early 2000s, with the one of the fathers of lead extraction in Australia, Neil Strathmore, in addition to the support of the Cardiac Society, went to the federal government to look for reimbursement of this procedure. And after a process that took several years, a reimbursement code was introduced around about 2006. This reimbursement code was somewhat unique at the time, in not only describing the procedure, that is a lead extraction, and it was decided that leads had to be in for more than 6 months and utilise specialised extraction tools. But equally, it had to be performed by an accredited extractor and it had to be performed in a unique location, that is a hospital with cardiac surgical backup. Interestingly, the cardiac surgeons, despite providing backup, weren't funded for a further 10 years. So what is an accredited extractor? So this was assessed independently from government by a subcommittee in the Cardiac Society of Australia and New Zealand. And to become an accredited lead extractor in Australia, you had to have evidence of your initial training, and then you had to provide evidence of annual performance of the procedure. And the committee then made a recommendation to the government and Medicare about continuing access to the reimbursement code. In terms of initial training, there were no local guidelines in terms of what defined initial training in Australia, but we used based on the position statements of HRS and the Europeans. It was set at a minimum of 40 extraction procedures of chronically implanted leads, with the trainee being the lead extractor in most of those procedures. It had to be formed under the supervision of an experienced lead extractor. A logbook had to be kept, and a CV and a letter of recommendation were required. In terms of annual recertification, this was really through a logbook, and the numbers of procedures required for recertification were modest. This really reflected at the time the procedure was relatively rare and also a recognition that Australia had a relatively small population and that we needed to service some areas because of geographical isolation. Initially, it was thought that at a minimum of 3 extraction procedures should be done a year, although you're allowed to do a minimum of 5 patients or 10 leads over a 2-year period. And the committee had the ability to withdraw certification if there was persistently no numbers or adverse outcomes. During that period, a number of people voluntarily stopped performing the procedure because of small numbers. Now, recently, in 2023, those numbers were revised quite significantly in sort of accordance with changes that have occurred in other parts of the world, and it was increased to 20 patients or procedures per year. And this was really the framework for lead extraction in Australia. Furthermore, the coroner or medical examiner had significant impacts on this framework because of adverse events. And there were 2 sort of adverse events that occurred during during years that sort of influenced this framework. There was a death around about 2007, 2008 in a hospital without access to cardiac surgery. A patient with 14-year-old pacemaker leads suffered sudden cardiovascular collapse, and it took some 45 minutes before imaging made the diagnosis. The patient died, and the coroner was quite critical of the lack of surgical backup and the lack of access to timely imaging. A second death occurred a few years later in a large metropolitan hospital with the presence of a surgeon. It occurred in the catheter laboratory, and while surgical rescue was attempted, the coroner was critical of the environment and particularly the lack of the ability of the surgeon to perform his job, particularly the lack of access to a pump. So this led to 2014 to another position statement about what is actually adequate cardiac surgical backup. It was first of all recognised that transfer to the operating room is usually too slow for effective salvage, and there had to be a balance between portable fluoroscopy and the cath lab. Anaesthetist should be present, and ideally the procedure should be performed under general anaesthesia. The patient needs to be appropriately monitored with arterial and femoral access. Patient need to be appropriately draped for surgical rescue in a timely fashion. There need to be timely access to imaging, particularly transthoracic and transesophageal echo. And a surgeon, importantly, had to be immediately available, not necessarily scrubbed, but certainly not otherwise occupied. And this really has moved to this procedure in Australia being almost universally performed in some variation of a hybrid operating room. This is our operating room at the Prince Charles Hospital. You can see it's a large room with access to high quality imaging and plenty of a room for the surgeons to perform their job if required. So what are the results of this framework in Australia? This was the experience presented by Neil Strathmore, the first chair of our lead extraction committee in 2018, and described the 10-year experience of lead extraction in Australia at that point in time. 2,360 odd patients had a lead extraction procedure performed, and just over 4,700 leads, or about 2 leads per patient, were removed. The procedure was performed by 18 accredited extractors during that period. Infection was the predominant indication at 70%. The success rate was high, and the need for emergency surgery was low at just over 1%, with an in-hospital death rate of 0.4%. There was, however, some significant regional variation. This graph here just shows the numbers of lead extractions performed in Australia. At the start, about 200 procedures were performed a year, and over the 10-year, that increased to around about 250 procedures. You can see the majority are performed in the large states on the eastern seaboard of Victoria, New South Wales, and Queensland. In terms of the indication, over that period of time, the predominant indication was infection and remained throughout the study period, except for perhaps at the very end, about 70% of those leads extracted in Australia were for an infective cause. In terms of the extraction rate per million population, it works out at about 10 extraction procedures done per million population. If you take into account the number of devices that were implanted in Australia during that period of time, it works out that about 10 patients per 1,000 implants, or just under 1% of all implants, require a lead extraction procedure. But again, you can see there's quite significant variation, and there's almost a threefold variation between the states with the highest rates of lead extraction versus the states with the lowest rates of lead extraction. And this appears to be not due to the rates of infection, but really due to the rates of removal of non-infected leads, with some states almost never removing leads because of infection, whereas other states have a more liberal use in sort of reflecting what is happening worldwide for this indication. So fast forward to 2023, which is the latest year that we've got a full set of results. The 2024 results were due a couple of weeks ago. So I'll just present those. In 2023, there were 12 hospitals performing lead extraction, a mix of public and private institutions. It was performed by 14 accredited lead extractors. The majority of those were electrophysiologists. And laser was now available in 8 of the 12 sites. In 2023, 316 procedures were performed. A small number of procedures were performed in Western Australia, and they weren't submitted to the committee as that extractor was retiring. And so it probably accounts for no more than 10 or maybe 15% procedures. In terms of the indications, in 2023, just over 50% were now for a non-infective indication, reflecting the change in practice that occurred over the 15 years. In terms of the institutions performing the procedures, 4 institutions performed probably 70% of the lead extractions in Australia, with a further 2 easily meeting the updated criteria of 20 patients per lead. But you can still see now there's probably 5 or 6 institutions that have performed a relatively small number of lead extractions, and that may become problematic into the future. So a total of just under 600 leads were removed during 2023, or equates to 1.89 leads per patient. And this, again, I think is a little bit smaller than the historical number of 2 and probably just reflects the move to more non-infective causes for indication for extraction. The types of leads removed, predominantly pacemaker leads in 70% of patients. ICD leads were just under a quarter, and 7.5% were coronary sinus leads. In terms of the outcomes, the success rate was high. Just under 99% of the leads were removed. That may include a few tips that were left in situ and were classified as successful removal. In terms of complications during that year, a little bit higher than what I would have thought, and there were 10 patients who had cardiac tamponade during that period, to give a rate of just under 3%. Of those, 8 required surgical rescue. The main injury was a tear in the SVC in 5 of the 8 patients. But importantly, cardiac surgical rescue was effective in 7 of the 8 patients, with 87% of the patients leaving hospital alive. In terms of the in-hospital mortality in 2023, it was reported at just under 1%. It was related to the 1 death from a tear of the SVC in an omelette that was unable to be repaired despite the best efforts of several cardiac surgeons and vascular surgeons. There's 1 patient died from heart failure about 20 days post-removal of the device, and 1 patient died from sudden failure of an epicardial system implanted at the time of lead extraction several days later. And then 1 patient died a couple of days after discharge from hospital suddenly, following an uncomplicated implant of a pacemaker. So it gave it a mortality of around about 1%. There are, however, challenges with lead extraction in Australia. Access to the hybrid operating rooms where these procedures are performed remains problematic, given the pressures from our other colleagues, our structural colleagues and our vascular surgeons. There still remains no reimbursement for consumables, which limits its ability to grow the procedure. The hospitals are not terribly enthusiastic about this procedure because they lose money. Maintenance of adequate volume may be problematic, particularly given the changes that have occurred recently, and there are limited training opportunities. So in conclusion, lead extractions performed by a small number of operators. The results are comparable to the large global registries. It is a high success rate, a low in-hospital morbidity and mortality, and importantly, the indications of infective indications have reduced over time. It probably remains underutilised, and there are significant barriers to this that relate to referral and, importantly, hospital reimbursement, which limits the hospital's enthusiasm for us doing more procedures. And I'll close there. And I'd like to thank both Professor Strathmore and Gareth Wynne, who are the chairs of the Lead Extraction Committee, for allowing me to share these numbers.
Thank you very much for these three presentations. Dr. Callahan, maybe I'll start from a question from the audience to you. There's a question about the first case you presented. If the inner coil is gone, could you have used multiple locking stylets? Now, I know you had difficulty advancing the locking stylet, but potentially advancing more than one.
Yeah, that's a good question. In the interest of time, I sort of abbreviated thing. I almost embarrassed to say, I initially got a locking stylet down, but it was a smaller locking stylet, and I got greedy, so I removed it thinking I'd go with a larger, maybe like an LD2. And I did have the thought of maybe passing multiple locking stylets, and it was with the second pass that I kind of started going between the coils. So I think it's a good idea. You maybe fill the lumen with multiple locking stylets if they would have passed, but unfortunately, I was just struggling with them constantly penetrating between the coils.
You and I encourage the other speakers to ask questions as well if you have any questions. You showed a tandem approach to snaring these fragments rather than a superior-only approach. We talk about tandem approach to snaring leads. Do you think, had you been able to pass the locking stylet initially, having a tandem approach is better than snaring from one side only? And that goes for your third case as well. You went from above and below.
Yeah, so absolutely. I even if I had been able to pass a locking stylet in the case of the fragment, my intent was to go with a snare from below. I just thought that with the distal end cut, that as Ziggy was pointing out in his great presentation, those two segments are going to now move independently. So as I created traction on, say, a locking stylet that's expanded in that outer coil, it could have just pulled everything out, and I'm not really getting a good traction on the outer insulation. Now, I would have bound it with a compression coil or suture or something, but really that outer insulation is so fragile. I really thought to get a good rail, I wanted some sort of a wire, preferably a locking stylet, but also a snare from below, so that when I'm pulling, I'm really creating traction on my rail as opposed to the more fragile components of the lead.
Yeah, if I could add to that, just to emphasize that point, when it's cut on both ends, in fact, removing the inner components can really be misleading because it can feel so easy. And this happened with us with one of our recent extractions after transplant. You thought you were winning because it can come out so easily, but you're not.
Yeah. I think that's right. So snaring from below in the cut leads is, I think, important. We were lucky, Ziggy brought up a point that sometimes you don't have access from the pocket, and then you're really just dead in the water. But we were lucky. There was a tiny little fragment that was extravascular that we could access. It took us a long time to sort of really gain control of it. But even if you have that fragment in the pocket, just cutting that distal end, even if the proximal end is still bound by a pin, things move in relationship to each other, and it's a different beast compared to extracting a lead that has an intact distal tip.
We've wondered also,
Sorry, go on.
Sure. Just with even when you can access that tip after it's been cut, one of my colleagues did a great case, Dr. Cronin, he dissected tremendously to find that little tip. And he was able to get out that fragment. But we've wondered about over time, depending on how old that fragment is, heme working its way into that existing lumen. And then all of a sudden you've done the heroic effort of getting that little tippity tip from the subclavian or where it pokes into the axillary vein, only to be stymied by heme that's in the lumen, and you can't get anything through.
Speaking of interluminal leads, I've spoken to surgeons in the past, and I've told them, maybe don't open the pocket, don't pull or cut it. We'll deal with it later. And sometimes the answer I get is, well, if I pull on it and it doesn't come out, it's fibrosed and it's never gonna get infected. What should I tell the surgeon when they say that? Because I'm sure that's something that we hear a lot.
Well, I don't think they're totally wrong, because just like leaving a tip in the RV septum that's totally encased probably gives you a good clinical outcome anyway, there may be scenarios in which a portion of the lead is completely fibrosed and you actually will be okay. One point I'd make is, great point, you're probably right sometimes, you're probably not right all the time. That's what I think I would say, that maybe, but unlikely that the full length of the lead is fibrosed. In fact, we see that when we extract. There are periods that are hard to get through and then segments that aren't. And just because a lead doesn't come out or a fragment doesn't come out doesn't mean the entire thing is densely encased in fibrosis.
Ziggy, I really liked the comment that you made about talking to the surgeon and asking him, if it comes out easily, go ahead. But if you meet resistance, just leave it be. I think that's probably a great response.
A picture's worth 1,000 words too. Our surgeons, I'm like all of you, I work with many, but also am friends with many. And it's not something they've thought about. That's a generalization, but it's not something as a group that they're thinking about. And when you pull them over in the side of the hallway, well, we're all in a rush. It's not that interesting a topic, but to see the chest x-rays or the CT scan that shows that the chest x-ray is misleading is such a powerful thing. And that's how we've sort of made the point at our hospital.
Can I just make a comment? Our institution's got a relatively small heart transplant program, 15, 20 cases a year. About 10 years ago, the surgeons used to cut and pull, like you've commented. About 10 years ago, after removing a device, they got quite a serious pocket infection. And so they abandoned that procedure. And for the last 10 years or so, the sort of standard approach has been just to cut the leads at the SVC and then ask us to take them out down the track. And we've taken out now probably about 60 patients, so 120 odd leads. And it's, we get them about 3 months down the track and remove them for the reasons that you say. I wonder whether we should really take them out, but I think it's the right thing to do for MRI and infections. The things that I've learned is that don't cut the pins. Leave the pins on and shave them back, and you have to use a big sheath, and you get most of them out intact. In saying that, they are more difficult extraction procedures than the usual ones when the leads are intact, because of the tendency for bits to come. They come out in bits. You come out, the inner bit comes out, then bits come out. So don't cut the pins, tie them down, and you can get most of them out. And we've got most of them out. There's a few early on that I was just learning what to do, but in more recent times, we take them out and the surgeons don't do anything at all. They just cut the leads in the SVC, do the transplant, get out, and then we come back down the track. And I think that's a reasonable approach. Cutting and pulling the easy ones, you think you could all do it in the same operation, and I think that would work. The surgeons just have to understand when not to pull or when to stop.
And Russell, just to clarify, they are, as a rule, just leaving the pocket closed. Don't remove the can. Yes. They do the transplant, and you get to see the patient enter the pocket for the first time.
Yes. So they don't do anything. They just cut the leads, do their transplant, and we get asked to see them, 6 or 8 weeks down the track. Occasionally, we've had to take a few out early because they're concerned with sepsis early on, and we take them out there. But most of them, we get them a few months down the track. And they don't touch the pocket. They don't do anything. So it's just like doing a fresh extraction in terms of the device. And see, we don't see those little bits cut off and where they've pulled and broken things. You get a lead that's, you can at least attack reasonably well.
I've often fantasized about living in Australia, and you just highlighted
It's gone up a bit.
Yeah, now exactly. One of the things that Tom, you said earlier was that when you had spoken to the surgeon after, I think it was your first case, he had the impression that the whole thing came out. And one of the things that I've learned from joining the Cooper School of Extraction is that one of the things that makes a person an expert in extraction, and I don't know that I'm there yet, is really, really knowing lead anatomy well, and that different leads have different anatomy. And it's not part of the surgeon's job, and therefore I say this completely without judgment, to know the lead anatomy. And a surgeon's examination of a lead after he's removed it is not likely to be as good as someone who's an expert in how leads are constructed. So that's not a really good sensitive indicator, as you pointed out, Tom, that of whether or not the whole thing came out. And neither is a chest x-ray.
No, you can, little bits can get behind.
I've heard it proposed in the past to if the patient is going for transplant electively, to open the pocket and do a mechanical extraction only up to the SVC, so that when they pull from below, it comes right out. Do you think that's an approach that's feasible or even recommended, or you would simply leave it as is for a later time?
I've thought about that approach, and then it all became too hard to sort of coordinate, do it at the time of transplantation, when the chest is open. It seems like a safe thing to do. The surgeons at our hospital, they're surgeons, and they want to do the operation, get back to the intensive care. In the one patient where we tried to do that because they had an infected VAD or something like that, and we thought we should take all the hardware at the time of transplantation, and there were bleeding issues around the transplant, and they said they're too sick, they have to go to the intensive care. You can do this at another day. I think it's just hard to coordinate, but it strikes me that, if you've got the chest open, that would be the timely thing to do it all together, because the risk of anything happening would be low because the surgeon's got direct vision. In saying that, I think these are cut high enough that, in reality, damage to the SVC is going to be pretty low, because they've cut the leads, above the pericardial reflection generally. So if they do bleed, it's into the mediastinum rather than into the pericardium. So we've had very little issues in sort of complications. In fact, no complications. The biggest complication is not getting the whole lead out.
Well, we've done that in a handful of cases, extract the proximal portion and then leave the rest for the surgeons. But as Dr. Denman points out, it becomes a real logistical challenge. I mean, I think from an extractor's standpoint, you'd sort of prefer to do that method where you've got access to an intact lead, you extract down to where you think the surgeons would be able to take over. So from an extracting standpoint, I think that would be preferred, but the logistical hurdles can be insurmountable.
Yeah, I've thought about that, but being on call for the entire year for the half a dozen transplants they do at 2:00 in the morning just does not fill me with joy. So I thought it's easier to do it afterwards.
Dr. Denman, I have to say, it's very impressive that you have data collection for the whole country and you're able to show us what you've shown us. What would you advise a physician who is starting a new program in a new hospital, or starting a program in a country that hasn't done extraction before? Have you seen any mistakes that you would advise a new person to not make, or something that would make their life easier going forward?
Well, I think you have to get buy-in by your institution. You have to get buy-in by the surgeons, because and that's easier said than done. I fortunately am at a sort of a large surgical unit where they just sort of, it all helped. But I think it's critical to get that buy-in to start with. You need to, partner with a a bigger institution. In some of those numbers, I suggest, institutions, they sort of pick out the easier ones, and the more difficult ones get sent to a person with a bit more expertise and a bit, more experience. We show that it's reasonably safe. I know that's answered the question.
That's great
That was the
looking
other
at
thing
those numbers, Dr. Denman. I'd also just like to chime in, one of your biggest challenges, I think, that you mentioned was access to the hybrid OR, and we feel that pain.
Yes. That's the problem, is that there's a lot of people want that space. I mean, I think that's clearly the space that we should be doing these procedures in, because I think, we all occasionally have major complications, and the surgeons are our friends, and they've got to be able to do their operation in the space that they're comfortable with. But it's very hard. There's lots of people want that space. And yeah.
That's just,
that's
sorry,
5 years old versus. No, sorry, Doctor. Go ahead.
I'm so sorry. Just as a complete digression, but you just made the point, Russell, that the surgeons are our friends, and we can't do lead extraction without them. And it's so easy to walk out of a 3-hour or 5-hour or longer case exhausted, exhilarated by your success, and forget to say thank you. And meanwhile, they've been on standby while you've been doing your job in their office, throwing a tennis ball against a wall, waiting for something to do or not do. And it probably would. It can never hurt to say thanks. And so, as a public service announcement to everyone listening, on your checklist when you walk out of that OR has to be call the surgeon and thank him or her.
Yeah, I make a point of that when you're doing the extraction procedure, there's the point where they can go home, and the theatre nurses ring the surgeons, and I thank them every week. I don't need them very often. And over the years, with sort of the few cases we've needed them, they've provided superb service. But you have to sort of thank them because they spend an awful lot of time waiting around doing nothing. And then it's a bit like landing an aeroplane. It's fairly boring, and then every now and then there's sort of moments of terror.
I've actually offered the surgeons to come in and watch as we do the extraction, even assist with some parts of it, and they've been very happy to do that. And then it's not that boring waiting for them as well, and they know exactly what we're doing as opposed to just know the complication aspect of it. Well, thank you very much to our speakers, and this was a great last session, and I will hand it off to Dr. Rob Schaller and for the social media wrap-up from Dr. Edmund Schloss as well.
All right, another great session and another great tales, and we're lucky enough to have Dr. Schloss, who's been tweeting all day. Nobody tweets a conference like Dr. Schloss. He's there morning, first one there and last one to go. So I was hoping that everyone could join us now, and he could give us maybe the top 3 or 4 trending topics on social media today, what people were interested in regard to the topics of the day. And we could discuss it for a few minutes.
Yeah, Rob, I'm sure you'll hear this a lot, but thank you. This was an amazing conference, and the other chairs as well are to be commended. I'm just going to lead off with one of the ones that got the most uptake was actually your protocol for venous occlusion, and I got involved in the panel discussion on that, and I'm guilty of somebody who's let these folks be until they're very far along. And I wonder if perhaps I think we have a couple other people besides you. If not, you can chime in where you've seen this evolve over time, and what do you think the future of aggressive treatment of venous occlusion will be for arm swelling, that particular reason? Yeah,
the arm swelling is a tough one because it's one rare, so people kind of poo-poo it a little bit, and it's just a swollen arm. They'll get better with blood thinners, but it might not. And you really have a therapeutic window, and if you miss that, there's going to be a problem. And the irreversibility can be mild. It can be just speckling of the arm, a little bit of discomfort when it's maybe hanging down, or it could be really horrible edema that's puffy that doesn't really respond to anything. So I think the message is this: don't let the sun come down. Is that the term on a swollen arm? Address it and get them on some blood thinners. And if it's not better within 30 days, just make sure they see someone that is adept at venoplasty, and it is rare. But I don't know, Josh, Mo, how often do you see patients like this?
Yeah, it happens, and thankfully, most of the time, as you highlighted, it has to do with acute thrombus formation, and you should be very immediate and aggressive with anticoagulation, and it often resolves. And also, of course, chronically, the venous collaterals that form for a reason, and that alleviates over time. It can take months or longer, the symptoms of arm swelling, and so often just time heals all wounds, but not everybody. And so I agree with you that we should be jumping on this aggressively up front. And I wonder, you obviously have established a great collaboration with peers in other disciplines, and I wonder what your advice is, because we are not venous experts, although we know a lot about it. Who should we partner with as we think about these patients, thankfully rarely, with arm swelling that doesn't resolve?
It's interventional radiology, but I would urge every electrophysiologist to learn how to perform venoplasty, because it's the easiest thing you're ever going to perform. It's so forgiving, it's so straightforward, and it's so safe. And you will, when you start doing it for implanting leads through stenoses, you will wonder how you ever got by without doing it. So first, you learn a lot from your interventional radiology colleagues, sometimes interventional cardiology or just more experienced EPs, and you will be off and running very, very quickly. It's not hard.
I have to say, I've been slow to react as well, and I really liked your presentation. I might act more quickly now to avoid the long-term sequelae.
I think one of the themes of the day, getting back to social media and people watching, and again, thanks to everybody who attended this amazing conference, and to those who will have access to the videos thereafter. This is so geared toward practical aspects. I mean, that's exactly the whole purpose of the inception of this conference, is not to talk about hypotheticals or this or that, but the actual nuts and bolts on the ground management of these patients before, during, and after extraction. That's what I take away from this that's so valuable. And I think that's where social media is so important. Lead extraction can be a very isolating silo type of experience, because many institutions have only one or sometimes two people who do it. And therefore, you're not exposed to other people who have knowledge base outside your own or have seen cases, each of them being unique, to help you with your unique case that you have now on the table. So the way that we learn from others is through conferences like this and social media and other ways of broadcasting, which really has supplanted, frankly, a lot of the papers that we write. Obviously, those are important too, but sometimes just single case examples like we've heard today are so valuable, and I don't know that we always think to publish those, and we pass them along to our trainees. I'm grateful and thankful, and hope that I've passed some of the things that I've learned on to Rob and Ziggy and others. But being able to broadcast these cases widely, I think is so valuable. So again, appreciate Rob, you're spearheading this great conference, and Jay for broadcasting it further on social media.
Yeah, well said. Jay, what else is resonating with people?
There was a theme that grew out, and it really started picking up in the panel discussion of the very last session. And I kind of broadened it out to being collaboration challenges. And so we talked earlier, got a lot of uptake on the disconnect between radiology and electrophysiology when it comes to MRI scanning. We've all felt that pain, challenges to address that. The issue of the transplant surgeons. Some transplant surgeons are probably more approachable than others. I remember Ziggy, the look in Ziggy's eyes when he wanted to move to Australia was I feel that as well, because I'm in a transplant center, and I don't think we have the same luxury of open dialogue that Dr. Denman described. And then these other issues regarding how do we decide upon venue? We've all been challenged by the collaboration with our cardiothoracic surgeons on what considers an appropriate venue, and how difficult it is in some centers to get extractions scheduled. And we felt that pain. We now have a hybrid room, but we've lived in the era of having to share a hybrid room with with our structural heart doctors and the pain that it shared. And I did hear from Dr. Dominic that he was doing his 5 to 10 year cases in the EP lab with ECMO, which is something we proposed but were shot down on. So that's a big topic, but just, maybe an anecdote from everybody about a challenge in collaboration that they've faced and how they've gone through it or how they haven't, so we can share your pain.
Mo?
Yeah, so one of our challenges in my center is a lot of times the cardiac surgeon is busy while we're doing the extraction. He's on standby and he's there, but he's he could be on pump, he could be so it's difficult to book these cases and to have them and I think it's really getting a buy-in from the surgeons and the hospital administration that these cases are priority and the mortality from an infection or the impact those leads have are as important as ischemic heart disease or heart failure or other diseases that we treat. So I still face these challenges all the time, day to day. But I think just bringing the message and having an open dialogue all the time and inviting them to partake in cases and observe, helps see things from our point of perspective as well.
Josh, the final word?
I was going to say, and bring it back to infection, one of the biggest areas of missed collaboration sometimes is in patients who are bacteremic with a device in place. And we have now an Epic tool that we use to find patients who have the coincidence of an implanted device and bacteremia, because we can't always rely on our infectious disease or hospitalist colleagues to call us when that shows up, and they often get managed with just antibiotics, and then they invariably come back with infection later. So I think it's an interesting art. How do you have access to other people, whether it's at a conference, a grand rounds, or it's certainly case by case is helpful, but maybe less efficient, but more effective. And then remembering always to approach people of different disciplines with great respect and compliments, because there's nothing that's going to cut short that collaboration than you criticize somebody out of the gate, whether it's a surgeon or an infectious disease specialist or an interventional radiologist. That's the end of your collaboration. So flattery will get you everywhere. And I think that's good advice in all of medicine and frankly, all of life, that when you're looking to establish a relationship, think of the positives and flatter the person, and then you kind of sneak in there the learning point, and then you're off to the races in terms of better collaboration in the future.
Diabolical, Josh. Well, on that note, I'd like to thank my co-directors and Dr. Schloss and all of the incredible speakers. I think this was the best Tales ever. We're ending, I think, a couple minutes early, which is pretty amazing. We are dedicated to keeping Tales completely free and with easy access to everyone throughout the world. And that wouldn't be possible without our incredible partners who have been so generous and so gracious for 5 consecutive years. And that is Medtronic, Philips, Abbott, Boston Scientific, Biotronic, Inari Medical, Kestra Medical, Merit Medical, and Zoll. Also the University of Pennsylvania and our organizer, Mediasphere. Please visit the virtual booths. And if you have any recommendations for speakers or topics for Tales 2026, please reach out to us. And if you want to claim CME credits, they are now available on talessymposium.com, where all of these talks will be housed, hopefully forever. And we look forward to seeing you again next year. Thank you.